We're going to open it up to questions in just a second here. I want to just make a few summary comments. So what you've heard are two talks about a procedure for using olfaction, which is basically a measure of brain health itself. It happens to be an area of the brain, the olfactory cortex, that's very near an area that is almost invariably damaged in Alzheimer's disease. And then you've heard two talks about looking for amyloid in the eye, either in the retina or the lens. And I'd say that although it is sometimes said that amyloid is Alzheimer's disease, I think it's important to keep in mind that amyloid is amyloid. It is highly associated with Alzheimer's disease, but it's not the same thing. So what we were hearing about here was actually a detection of a biochemistry that is strongly related to Alzheimer's disease. And finally, I just want to make a point, or 2 points actually, keep our terminology straight, that when we're talking about Alzheimer's disease here, I think it's really important to keep in mind that we're talking about the underlying biology. When we're talking about people who are cognitively normal, who might have that biology, we're talking about people with mild cognitive impairment or people with dementia. So when sometimes that terminology gets can be misleading or confusing. And the final point I think that I want to make, and I think it is well known to everybody here, is that unfortunately our field lacks a powerful therapy or any therapy to prevent the disease or to stop it in its tracks at this point. We understand that, but the kind of approaches that are being described here are the things we need to have in place when we have those. So, Niles, if there are no other comments, we can ask for questions from the audience.
Hi, Shirley Wong with the Wall Street Journal. Questions just sort of generally for everybody, especially probably for the odor detection folks, but what other conditions might be also associated with problems with odor detection, identification, and similarly with the retina or the lens, and then with the two of you specifically, what would be the advantage perhaps of screening the retina versus the lens?
So, go ahead, Deb.
So the odor identification test is affected by many factors: smoking, allergies. Some people just were never good at identifying odors. They have what is called congenital anosmia. There are other diseases where odor identification is affected, most commonly Parkinson's disease, schizophrenia, a number of other relatively rare neurological syndromes called the Guam complex. So if it is going to be used, one must recognize this. While most of these other conditions are relatively uncommon in the older population, that has to be taken into account if one is going to use it either as a screening test or for early diagnosis.
So the point is it has some specificity issues. That's a word. And now to the retina and then the lens.
Okay, yeah. So I guess I'll refer to your question about differences looking between the retina and the lens. Firstly, it's a good thing, I think, that we look in lots of different avenues, including olfaction, etc., because with science, that's the great thing. We don't know where the answers are going to come from. For us, we're both looking at the eye and at the protein that's involved in Alzheimer's disease in the brain. We think the retina is more likely to faithfully represent what's happening in the brain because it's almost like a piece of brain outside of the brain, similar tissue, similar vasculature shed, blood vessels, etc. And we're seeing pathology which is very similar to what we see in the brain. We do a lot of work outside of this trial on animal models and in human post-mortem work where we actually delve into depth of the pathology in the retina and compare it to the brain, and we're seeing a lot of similarity there. So we think that's a good way to go, but we won't know until the studies are finished which one leads to the best results.
What we found in the lens of the eye, it's not directly connected to the brain, but Alzheimer's disease is actually known to be a systemic disorder, and it turns out in the lens, all of the molecular mechanics are there to actually generate amyloid. And what we've seen in our studies is that it parallels what's going on in the brain. But there are some advantages in that it is metabolically not as active. And we find that A beta accumulates there. It doesn't wash out or it doesn't have to travel there and deposit there. It actually is manufactured there. So, in the basic studies, we've seen that it's very specific to Alzheimer's disease. In looking at eye-brain pairs of people with other neurodegenerative diseases or who passed away from other neurodegenerative diseases, we're concerned that with the retina that there's a bit more of a challenge in terms of confounding pathologies. Other reasons for A beta being manufactured there. As I say, we've now gone through 2 studies, and we feel as though our clinical results sort of stand on their own.
But just I agree with everything you said, but the whole reason why we're here is that Alzheimer's disease is not systemic. It's a disease that pretty much is in the brain, and that's been our great challenge. We don't have blood tests. We don't have skin tests. And what you guys have done is what's so fantastic. You found places where that rule is violated. And that's really the key here. If it was a systemic disease, we'd have a blood test, and we don't easily now. We won't get into that.
Oh, I'm Michelle Sullivan. I'm with Clinical Neurology News. So, Dr. Hartung, you mentioned that you think that the lens amyloid test can be used to rule out Alzheimer's disease?
Yes.
I mean, have you done longitudinal studies that show that?
We have not.
So, is that a bit overreaching?
We've done it through cross-sectional studies.
But you don't have a longitudinal study that tracks progression or transition.
No, what we've leveraged is the fact that PET imaging has done correlation to the brain. We've done correlation to PET imaging, and in the same way that PET imaging has achieved a claim of ruling out the disease. If you don't have A beta in the brain, you don't have Alzheimer's disease.
Mm-hmm.
We've seen that correlation between the eye and the brain.
But you don't think that is a little overreaching to say that you can use it to rule out?
No.
Caroline Castles from Medscape Medical News. Dr. Frost, I'm just interested in the backstory of curcumin and how you came upon that as a contrast agent, and also what does it taste like, and how safe is it? I assume it's safe, but just curious.
Yes, I make it a point of tasting things I give my participants in research studies, and I did try it. It tasted fine. It's the trickiest thing with the proprietary supplement that we give is getting it to be soluble, so mixing it up, there can be a problem for participants a little bit, but no, it's easily consumed, and it's quite bright and yellow. It's very much like the turmeric if you use that spice at home. And in terms of how we came upon it, there's been quite a bit of research around the fact that it adheres to plaques, that it binds to plaque, mostly actually to do with the possibility that might actually influence the disease, because we believe the plaques are a main pathology in Alzheimer's disease, and this curcumin adheres to them and may interfere with the way they build up, may even be able to clear them apart. So there's some trials going on around whether it can actually intervene as a treatment in Alzheimer's. But because it also has those fluorescent properties that helps us highlight the plaques, it's become a hot topic for us to be able to detect Alzheimer's early in the retina.
Sorry. Is it true there's a lower incidence of Alzheimer's disease in India?
I can't answer that in completeness. I have read some papers about that, and the studies that I read had some study design problems in that they didn't deal properly with age, so lifespan differences, etc. And I think that's part of where some of this interest came about, and some of those results. But whether that's the case, they're very different populations to look at, and there's lots of other confounding factors. We're not entirely sure whether that's making a difference. To be truthful, we need to use a lot more curcumin than would be in a normal person's diet who eats curry even every night. So it possibly wouldn't be influencing at that sort of concentration.
Obviously, you mentioned that the pathology is known to start decades before symptoms might occur. Any speculation on the various tests that you're developing, how far in advance you might actually be able to use the test to be clinically useful? You know, are we talking just a couple of years before symptoms onset, or a decade or more?
Why don't we start with, go down turn the other microphones off. We'll go one at a time here.
I actually personally am not. I wouldn't be able to speculate as to how far ahead, but I think one thing I'm thinking about as I hear all of these different modalities is that we just don't know. It may start in different places in the brain, or have you could imagine a panel of tools that use different modalities all at once, just to make sure that you're catching everyone. Because as we've discussed, the diagnosis is so crucial. You would never want to miss it, and you would never want to be wrong about it. So I'm conceptualizing it, at least for the purposes of today, as potentially looking in the eye as well as smell modalities, and then even using some of our more known biomarkers.
I would agree with that. One point which I alluded to, and I think should be emphasized, is that while any test could be useful very, very early on, maybe as you said, a couple of years earlier, maybe a decade earlier, the accuracy in prediction of the test is actually, as we saw with the olfaction data, and I assume this will occur with a variety of diagnostic markers, no reason to believe it wouldn't, the accuracy increases from the asymptomatic stage to the stage of MCI when you're predicting Alzheimer's, to the stage where you're distinguishing Alzheimer's from controls. We've seen that, I know, with olfaction, with MRI measures, a variety of measures. So even though we talk about very early detection or very timely detection, as Dr. Knopman said, the accuracy of that is going to be less in normal populations. And I think it's important to consider that in addition to the exact timing, because the timing is, as Dr. Groudon said, still a matter of some guesswork. We know it's much earlier, we just don't know exactly when.
So we're testing our eye test on the ABLE cohort in Australia. It's a large cohort of volunteers who have been tested over the last about 8 or more years. So these people come in every 18 months or so and get testing. And from studies like these, we've built up a picture of the kind of changes that happen to people in the early stages of Alzheimer's disease as we follow them. And it seems that things like the plaque deposition in the brain happen. Also, perhaps slightly earlier than that, changes to the cerebrospinal fluid, the concentrations of beta amyloid and another protein called tau involved in Alzheimer's. And then later on down the track, atrophy to the brain, so the brain starts losing cells, cognitive changes, so start losing performance in memory, etc. That's the sort of sequence of changes that we see happening in the early stages of Alzheimer's, and that starts, we can tell, about 30 years before diagnosis is currently happening. So that's the kind of time frame we're talking, and it's that plaque deposition right near the beginning of those changes that we're comparing the eye test to. So that's the sort of time frame that we're looking at.
Yeah, and building off of all of the comments that have been made already, in the lens specifically, we have seen in animal models that the A beta starts to form about the same time that plaque starts to form in the brain.
I think it's important to keep in mind when you see amyloid beginning to appear, let's just say in the brain where we have a little bit more evidence, but it's still less than 10 years old at this point, that, first of all, that's not dementia, that's just the pathology of amyloidosis that probably, or that we think is Alzheimer's disease. The time frame is highly variable, and the time or whether people develop symptoms, as Dr. Devonen said, even in somebody who has brain amyloidosis is still uncertain, but the risk is certainly higher.
Susan Jeffrey from Medscape Medical News. I'm interested in the opposite. Can you give a bit of background on who developed that as a proprietary thing? And Dr. Devonen, you talked a bit about certain changes that were made in some of the contents of the test that, and also then if you could talk a bit about, because it's in the here and now and doesn't need machinery and so on. How would you see that being used in the clinic, and when?
Okay, the upset was developed by Dr. Richard Doty at the University of Pennsylvania. He subsequently created a company called Sensonics, which sells it. It's fairly inexpensive. I believe it's about approximately $25 a test. The way it was originally developed, he developed it in collaboration with the 3M company, Minnesota Mining and Manufacturing, because most of the upset odors are actually chemical odors, which are indistinguishable in our human way of smelling from the original odor, say an apple or a pear or any such odor. So the standardization was very strict. It was done, I believe, about 30 years ago, maybe a little more. Subsequently, the manufacturing is no longer done by the 3M company. It was transferred over to another manufacturer that has maintained the same standards. The upset is not the only smell identification test. In Europe, there is a test called the sniff and sticks, which has I believe it's a German company that does that. It has one advantage, which is it can be reused, whereas with the upset, you scratch and sniff, the odor is gone, and you have to discard the test after you use it. Whereas the sniff and sticks has a method in the terms of the way it is administered. There's enough of the odor that it can be used for a number of subjects. So actually, it's even less expensive if you take into account the fact that you can use it repeatedly. And there are one or two others, but as far as I know, those are the two ones that are widely used, at least in research. And I don't believe there's any clear advantage for any one test over the other.
So going forward, how would if the tests are out there and available, people might be tempted to sort of start using them at this point, but what should technically happen before that would be something that would be used widely?
You want to comment on that?
I think one thing for sure is that we'd like to see a much larger population-based study following large numbers of people over a long period of time to better understand in a large group that's a very powered study, kind of what this is picking up on and whether it bears out that it's actually predicting some sort of onset of cognitive decline or onwards to mild cognitive impairment or Alzheimer's disease dementia. Because at least in the data that I presented, it was just 215 of these asymptomatic individuals, and it was just a cross-section in time. And I think Dr. Devenon's study does have a longitudinal component, but it's still relatively short when you think about, as Dr. Notman was saying, how long ahead of the onset of symptoms we're looking. So I think there's still a lot to be done to prove its worth before you could use it in the population.
For those tests that you envision as moving into, and actually for the upset, which is already used, how do you counsel patients who come back positive on that? And then for the other tests, would that counseling be similar, or how would you handle that? Considering you might be identifying people who are in a really early stage of amyloidosis.
The way the test is done in our clinic and even in research settings, I believe, is that it's part of an evaluation, which involves testing for memory, description of how the patient is functioning from an informant based on the setting, the MRI scan, the FDG PET scan, or the amyloid imaging scan, or a spinal tap, which actually is very good at distinguishing Alzheimer's from controls as well as predicting the transition from MCI to Alzheimer's. So, and also there's genetic factors like the APOE genotype. So the way testing is done, and I think everybody on the panel would agree, it is not that one test is going to give you 100% accuracy for who does or does not have the disease, or who is or isn't going to get it. It's done in a context. So in counseling or advising patients, it's done in that broader context. Well, you did this well on the memory testing. This is how you're functioning. this is what the imaging shows. Therefore, it's more likely or less likely that you may have it, and this is what it means, and bring it into the clinical context also of that individual's own personal history and development of symptoms.
I think we need to break at this point for time reasons. So thank you very much. I'd like to thank the panel for their participation and thank you from the media for being here.